Good morning, everyone, and welcome to our Friday morning journal club for Thyro multidisciplinary seminars. We are joined this morning by a truly elite group of clinicians and a highly international one to talk about active surveillance of small metastatic lymph nodes as an alternative to surgery in a select cohort of patients with low-risk papillary thyroid cancer. Our speakers this morning are Dr. Pitoia and Dr. Sugitani, both of whom have been on this platform many times in the past and are considered experts in this field. I am really thrilled to be able to also announce that Thyro has launched its first of several podcasts, which will be coming out on a monthly basis. These podcasts are scheduled to launch every month, and so I ask that you keep an eye out for them. And I think that these 15 to 20-minute sessions, I think you will find to be extremely informative, and this is something that the Thyro Board of Medical Directors has committed to delivering on a monthly basis. So this morning, our presenter is Dr. Fabian Pitoia, who is the chief of the thyroid section of the Division of Endocrinology at the University of Buenos Aires. He is former president of the Latin American Thyroid Society. Dr. Pitoia really needs no introduction. He's widely recognized as a leader in thyroid cancer management. He has over 300 peer-reviewed publications and is highly sought after as an international lecturer. The board of Thyro is very pleased to have him as an active member of the board of directors. And this morning, our discussant is Dr. Iwao Sugitani, who also really needs no introduction. He is a graduate school professor and chairman of the Department of Endocrine Surgery at the Nippon Medical School in Japan. He is vice chair of the board of directors of the Japan Association of Endocrine Surgeons and a member of the board of directors of the Japan Thyroid Association. He's internationally recognized as a leader in the movement toward active surveillance of low-risk papillary thyroid microcarcinomas. He has published extensively and has contributed greatly also as a member of the Thyro Advisory Board. And with that, I'd like to hand over the platform to Dr. Pitoia to present this article which he authored. And as always, I ask that our listeners send in your questions, and as time allows at the very end, I will do my best to get to them. So Fabian, thank you very much, and look forward to your presentation.
So thank you very much for the invitation, as always, and I'm proud to share this with Dr. Sugitani, who I admire a lot, and so I'm happy to share our investigation about active surveillance of a small metastatic lymph nodes. So I have no conflicts of interest to declare for this presentation. And as an introduction, I want to speak about the risk of recurrence. We know that when we talk about the risk of recurrence, we are very familiar with all these, and probably this will be changing in a few months with the new guideline. But what we know is this risk of recurrence classification helps us to establish the risk of a structural incomplete response or excellent response to treatment. And mainly when we talk about low risk and intermediate risk of recurrence, we are talking about structural incomplete response in most of these patients with low risk and intermediate risk of recurrence in the lymph nodes. So this is a pretty frequent situation that we see every day in our practice. This, whether we use the first classification, the 2009 classification proposed initially by Michael Nodal, we know that this is easily taken and easily been applied in different scenarios around the world. And in the right part, you can see here our first validation of the guideline in 2015, when the guideline, the American Thyroid Association modified risk stratification system was published. And here we have that in our population of patients, 4% of low-risk patients had a structural incomplete response, and 14% of patients with intermediate risk of recurrence had the same situation, structural incomplete response. And in all these patients, these were lymph node metastases. So what does the guidelines say, the American Thyroid Association guideline, regarding the management of these persistence of recurrences? Well, final aspiration biopsy should be performed when these lymph nodes are larger than 8 millimeters in the central compartment or 10 millimeters in the lateral compartment, considering the minor diameter. Always, if the findings will change decisions in the future. So there are also ultrasound features of lymph node predictive of malignant involvement, like microcalcification, the cystic aspect, the peripheral vascularity, the hyperechogenicity, round shape, and the absence of hyalin. Another important point is to understand that if these patients undergo surgery, not always will be considered free of disease or with no evidence of disease, well, considering the biochemical and structural response. And if we look at this series, what we can find is that biochemical remission is not as frequent as the no evidence of a structural disease. We have almost between 50 and 100% of these patients who undergo a new surgery after an initial structural incomplete response who present with no evidence of a structural disease during long-term follow-up, but biochemical remission is something that doesn't happen as frequent as this, and it may happen between 20 to 66% of patients. It means that a lot of patients continue with detectable thyroglobulin or thyroglobulin antibodies. Another thing that we showed in our patient, and it was shown by a lot of other authors around the world, is that when you have a first structural incomplete response, then you have a larger risk of having a new structural incomplete response. And look at what happens for the low risk of recurrence when you have an initial structural incomplete response that it is only 4%. The probability or the frequency of having a new structural incomplete response increases to 28% and 54% for those patients with the intermediate risk of recurrence. It means that those patients who have a structural initial incomplete response have a larger probability of having new structural incomplete responses during follow-up. So another important point is the post-surgical complications that we usually have after reoperation, and it tends to be higher than we usually have with the first surgery, with the prevalence of hypoparathyroidism, permanent hypoparathyroidism that may go from 0 to 10%, and unexpected vocal fold paralysis that can go also from 0 to 6.4%, which is not a low percentage. Just to bring you, it has nothing to do with reoperations, but just to show, this is a group of patients who had a low-risk papillary thyroid cancer, who did not undergo active surveillance, and we here show what happens with the decisions of total thyroidectomy taken by surgeons and patients. Although we indicate lobectomy, most of these patients move to total thyroidectomy, 98%. And in low-risk papillary thyroid cancer, at least in our experience, we have a high frequency of permanent vocal cord paralysis, 2.2%, and high frequency of hypoparathyroidism, permanent hypoparathyroidism, that is 5%. We also know that active surveillance is an alternative for low-risk papillary thyroid cancer, and this is pretty shown with many studies around the world, knowing that the growth of these tumors may be less than 10% in at least 10 years of follow-up, and the structural incomplete response in this group, I mean, the development of lymph node metastasis seems to be pretty similar to what it happens for those patients who receive total thyroidectomy, lobectomy, or total thyroidectomy plus radioiodine. So this is in the frequency of 5% in 10 years of follow-up. Additionally, we know that active surveillance is an alternative for those patients who have radioiodine refractory thyroid cancer with tiny metastatic disease in the lungs. When we have these lesions, we usually wait until there is progression, and these lesions may remain stable during several years until they start growing up. So if we propose active surveillance for low-risk papillary thyroid cancer and also for distant metastases, can we also consider active surveillance for metastatic lymph nodes? So this is our publication in Thyroid in 2022. We wanted to assess the frequency of growth and the need of additional treatment in a group of patients with lymph node recurrences selected for active surveillance, and to determine the predictive factors for these outcomes. As secondary objectives, we wanted to assess the presence of local complications related to tumor growth, to evaluate the development of distant metastases, and to estimate the progression-free survival in this cohort of patients. So from 856 patients, we included adult patients who received total thyroidectomy with a more than 12 months of follow-up. And here we selected a group of patients with suspicious cervical lymph nodes on consecutive neck ultrasound after surgery. And these were 80 patients, and the exclusion criteria were that we didn't have a patient with a lymph node, suspicious lymph node larger than 2 centimeters in any diameter, or 2 lymph nodes larger than 1.5 centimeter, that they were proximate to vital structures. A PET positive scan with an SUV larger than 5 was another exclusion criteria for our patients. Having aggressive histology, malintol cell cancers, and distant metastases. So finally, we had 50 patients that had cytologically proven lymph node metastases. And these were the patients we analyzed in this study. How we did the follow-up, as usual, with thyroglobulin and anti-thyroglobulin antibodies measurements and the levothyroxine treatment. Most of these patients have TSH less than 0.4 milliunits per liter, and neck ultrasound every 6 to 12 months. The ultrasound was performed by the same radiologists with expertise in thyroid cancer, and we consider that the increase more than 3 millimeters in any dimension was showing an increase of diameter with a sub-analysis with an increase of more than 5 millimeters. The percentage of patients who needed salvage surgery and also who needed radioiodine, and the presence of local complications related to lymph node growth. So these were the baseline characteristics of our 50 patients included in the study, with a median age of 43, range 18 to 79. The time from initial surgery to find these structural incomplete response, the median time was 3 years, from 1 year to 13 years after initial treatment. The follow-up was 29 months, 1 year to 12 years. The range of follow-up, most of these patients were female, most had a classic variant papillary thyroid cancer, and a third of these patients have received total thyroidectomy only. 26% total thyroidectomy with central neck dissection, and 44% total thyroidectomy with central and lateral neck dissection. Only 16% of these patients, 8 patients, had not received remnant ablation. Most of these patients were low and intermediate risk of recurrence. The initial thyroglobulin level was 1.4 with the range 0.4 to 4. And there was 26% of these patients with TG antibodies positive. 26% had received a previous surgery in the neck, and the main reason to start active surveillance was the size of the lymph node in 92% of these patients, and multiple neck dissections in only 4 patients, 8% of our patients. So the characteristics of the lymph nodes under active surveillance, considering ultrasound, we found that most of the patients had a hypoechoic lymph node, 32% absence of hilum, cystic changes, round shape, increased vascularity, and microcalcification, as it was previously shown as the features that are very characteristics of or suspicious of metastatic lymph nodes. Of course, all these patients had at least one of these suspicious characteristics, but 64 had 2 and 3, and 24% 3 or more of these characteristics. Localization of the neck metastasis, neck lymph node metastasis, were mainly in the lateral neck. You can see that most had in the level 3, 4, and 5, but there were 32% of patients having lymph node metastasis in the central compartment. The number of suspicious lymph node was mainly 1 in most patients, but there were a group of 24% of patients having 2 lymph nodes and only 2 patients with 3 small lymph nodes. The number of patients with lymph node larger than 1 centimeter was half of the patients, and the baseline size of the lymph node in millimeter was 10 millimeter with a standard deviation of 4.4. So what happened with these patients? After this median follow-up of 29 months, the increase in more than 3 millimeters was 24%, and the increase in more than 5 millimeters happened in 8% of these patients. When considering the group of patients who had an increase more than 3 millimeters, 5 of these patients continued under active surveillance, and 4 received radioiodine remnant, radioiodine additional radioiodine dose. 3 had stable disease, and 1 had a decrease more than 3 millimeters. And 7 patients had surgery, a salvage neck dissection, and 2 had an excellent response to treatment, and 5 an indeterminate response due to thyroglobulin levels. None of these patients presented with local complications or new metastases. The progression-free survival in patients under lymph node active surveillance was 6.6 years, with an interquartile range of 95% between 5.6 to 9.5 years. When we performed the univariate analysis for factors predictive of lymph node growth, we did not find any variable predictive of growth, nor the age, nor female sex, the risk of recurrence, the radioiodine dose, the number of lymph nodes, the neck location, this number of ultrasonographic suspicious features, the initial diameter, the antithyroglobulin antibody increase, or any of these variables were predictive of lymph node growth, but the thyroglobulin increase in more than 0.5 nanogram per ml which was statistically significant and showed that this is a good marker to predict lymph node growth. The progression-free survival in patients under lymph node active surveillance according to the thyroglobulin increase was calculated, and here we can observe the progression-free survival for those patients who have a stable thyroglobulin or increase less than 0.5 nanograms per ml. It was 82% at 40 months, compared to an increase larger than 0.5 nanograms per ml with 28% at 40 months with a statistical significant difference, and an odds ratio of 16.24, showing that this is a factor predicting an increase in the lymph nodes. So when we look at some other previous series of patients with lymph node active surveillance, there are most of these patients in the first studies performed by Robenstock and Rondeau from the group of Michael Tuttle, showing that they had lymph nodes that were suspicious or thyroid bed nodules that were not cytologically proven, and the increase in this patients was 20% in the Robenstock study in 2012, with 9% with an increase more than 5 millimeters. This is pretty similar to what we saw in our study. The group of Rondeau showing 8% of increase, considering that these are thyroid bed nodules, not all of them lymph nodes. The study of Tomoda showing an increase also the 20% with an increase of 5 millimeters in 8%. The group of Maciel showing an increase near 50%, but here there were included patients with aggressive histology and distant metastatic disease. And a paper that was published after ours, the group of Ana Luisa Maya in Brazil, showed an additional interesting variable that is not only the growth of the lymph node, but the appearance of new metastatic disease, new lymph nodes. And it was 17.5% for the growth and 17.5% for the new development of new lymph node metastasis. So it gives a progression of 35%. Finally, this year, Solórzano from the group of Dominguez in Chile published a similar study to ours with an increase of more than 3 millimeters in 12.5% of the patients. Well, which are the factors or the variable predictive of lymph node in these different studies? In the study of Robenstock, the female gender was predictive of the increase more than 5 millimeters. The larger lymph node at study entry and the TG increase more than 0.5 nanograms per ml, similar this last variable to what we found. The group of Rondeau showing increasing TG, microcalcifications, and increased vascularity. The study of Tomoda showing that nor age nor size of the primary tumor were statistically significant predictor of growth, but an increase of 3 millimeters per year was related to mortality in patients with distant metastatic disease. And finally, the study of Solórzano showing an increase in TG predictive of lymph node growth, mainly the delta and the percentage of TG change. So the limitations of our study is, of course, the retrospective nature, and of course that these indications of moving with new surgeries or moving with active surveillance is very difficult to identify in this real life scenario, this conversation that we have with our patient to move to one or other situations to define what these patients do. The selection bias for the patient included, our cohort represents a very small group of patients selected for active surveillance and presumed to have a low risk of progression because we excluded aggressive histology, we excluded patients with aggressive behavior, like, for example, having the PET-CT scan showing a SUV larger than 5. And we have a young patient population with a median age of 41 years. We had short follow-up for some of these patients and a small sample size. And of course, these results might underestimate the real rate of progression in differentiated thyroid cancer. So as a conclusion, in a carefully selected cohort of thyroid cancer patients, only 24% with small lymph node recurrences selected for active surveillance showed this growth of more than 3 millimeters with no evidence of local complications or new metastatic sites. So active surveillance of these small lymph nodes could be the feasible alternative in properly selected patients. Thank you very much.
Hello, everyone. I'm Iwao Sugitani from Tokyo, Japan. It's a great honor for me to be here, and I'm thrilled to discuss with Fabian and all of you today. I have no financial disclosure to declare for this presentation, but I might be a bit biased, be a minimalist, because my great mentor, Professor Yoshihide Fujimoto, had put a great influence on my way of thinking towards thyroid cancer management. Thanks to esteemed predecessors such as Dr. Fujimoto and Dr. Akira Miyauchi, Japan's management policy for papillary thyroid carcinoma, PTC, has been established as a conservative approach that then considers the patient's quality of life. Historically, lobectomy has been actively performed for PTC, and clinical trials for active surveillance in very low-risk PTC began in the 1990s. Since the first edition of the Japanese thyroid cancer management guidelines was published in 2010, risk-adapted management policy, similar to the 2015 American Thyroid Association guidelines, has been adopted. Lymph node dissection has generally involved selective dissection. This means that a central neck dissection is performed in all cases, and lateral neck dissection is conducted when preoperative imaging indicates positive metastasis. Having said that, even low-risk PTC can sometimes recur and be fatal. It is certain that without recurrence, there would be no mortality due to the disease. While the existence of harmless subclinical or occult carcinoma has been known for a long time, recent reports indicate that the mortality rates from thyroid cancer have remained unchanged despite the increasing detection of small PTCs. It is also well known that the prevalence of differentiated thyroid carcinoma in autopsy studies exceeds 10% and has stabilized since the 1970s. These facts have brought the issue of overdiagnosis and overtreatment to the forefront on a global scale. As I mentioned earlier, trials of active surveillance AS for very low-risk PTC began in Japan in the 1990s, and now it has expanded globally. Also, multiplicity is not considered as a significant prognostic factor and does not necessarily require completion thyroidectomy after lobectomy. As for lymph node recurrences, they are commonly detected by ultrasound following initial treatment for PTC. However, most patients with PTC have excellent survival rates, even with lymph node recurrence. As Fabian mentioned, I'd like to introduce a study from Japan published in 2016 by Tomoda et al. This retrospective study examined watchful waiting for lymph node recurrence. A total of 83 patients with lymph node recurrence were assessed over a median follow-up period of 7.2 years. Of these, 20.5% showed an increase of 3 millimeter or more, and 8.4% had an increase of 5 millimeter or more. This study investigated the risk factor for disease-specific survival and revealed that the older age and lymph node growth of more than 3 millimeter per year was significant. Here, we present a case that we experienced. In 1995, at the age of 32, the lady was diagnosed with a 15 millimeter PTC and underwent a right lobectomy and central lymph node dissection. In 22, at the age of 39, a 14 millimeter lymph node enlargement was noted on ultrasound. But following Dr. Fujimoto's advice, the patient was placed under observation. After moving for family reasons, the patient was diagnosed with PTC metastasis in another hospital in 2006 by a fine needle aspiration and was advised to undergo surgery. Consequently, the patient returned to us for consultation. As there was no significant changes in the size of the lymph node, we recommend continuing with the observation. Currently, at the age of 61, the patient showed no particular changes and continued annual follow-up. In this context, I'd like to refer to Professor Mike Tuttle's review. To effectively manage recurrence of PTC, it's crucial to recognize that highly sensitive tools that detect small volume diseases that might not necessitate intervention. Key factors distinguishing between findings that require action and those that do not include tumor volume, location, growth rate, symptoms, and patient preference. Today, I have reviewed the excellent paper by Professor Pitoia and colleagues. This retrospective study focused on active surveillance of small metastatic lymph node in low-risk PTC. It has a very strict inclusion and exclusion criteria. All the patients had cytologically proven lymph node metastasis, and lymph node size and the proximity to the vital structures are meticulously evaluated as an exclusion criteria. As for the low-risk PTC, was defined that the excluded the PET positive, aggressive histology, and distant metastasis. All patients had total thyroidectomy, and 84% had radioactive iodine ablation. A total of 50 patients were assessed with median follow-up 29 months. The major aims of this study is to assess the frequency of growth and the need of additional treatment, salvage surgery, and to determine predictive factors of lymph node progression. Here, they defined lymph node growth as an increase of 3 millimeter or more in any of its diameters. As a result, increase in lymph node size was seen in 24% of the 12 patients. Salvage surgery was done for 7 patients, and no one showed a structural incomplete response. Remaining 5 are continued active surveillance, and originally remain stable patients. The majority accounts for the remain stable, 38 patients. Median proliferation-free survival was 6.6 years, none developed. Importantly, no one developed local complications or distant metastasis. Multivariate analysis of predictive factors for lymph node growth showed that patients with an increase in thyroglobulin levels had a significantly higher likelihood of experiencing lymph node growth. Here, I was wondering that the velocity until the increase occurred does not matter, or in cases with thyroglobulin antibody positive, could its trend serve as a prognostic markers? Anyway, I think that the key strength of this study is the meticulous selection of participants. They are adhered to the strict inclusion and exclusion criteria to ensure that only appropriately suitable patients were included. Another significant aspect of this study is the investigation into predictive factors for lymph node enlargement, focusing on dynamic risk factors, namely thyroglobulin. Overall, the methodology and comprehensive follow-up employed in this study provide valuable insights that could potentially improve the management of patients with PTC, reducing unnecessary interventions while ensuring timely treatment for those who need it. There are some questions for Fabian here. The question number 1. I was a little bit surprised that all the cases had total thyroidectomy. Lobectomy is now recommended for low to intermediate risk PTC, while dynamic risk stratification originally evaluated recurrence risk after total thyroidectomy and radioactive iodine treatment using thyroglobulin and thyroglobulin antibody levels. Recently, dynamic risk stratification is being applied in cases without RAI and even after lobectomy. However, its sensitivity and specificity are considered to be lower compared to cases of total thyroidectomy with RI. I'd like to hear your thoughts on advantages and disadvantages of lobectomy for low-risk PTC.
Thank you.
I have 4 questions, so may I end it up?
I can, if you want, I can be, I don't know what Mark thinks, but if you want, I can be answering so we would not lose and we go by order. This is a very important question, I think. I showed you because I wanted to introduce what happens to our low-risk patients with the decision of total thyroidectomy and lobectomy. This paper we published in 2020 showed that a group of patients that did not want to undergo active surveillance of a low-risk papillary thyroid cancer, I mean, 75% of our patients do not accept active surveillance. It means that most of our population are maximalist, and although we take all the explanations to show that this is a good alternative, they will finally move to total thyroidectomy. And total thyroidectomy is mainly chosen. We define lobectomy and we say we can only go to lobectomy because it is proven that everything will be okay. But when the patients go with the surgeons and the surgeon explains that probably there is a 10% of patients that need reoperation, and most of these patients find themselves in that place. And so they don't want to go for a second surgery and they mostly move for total thyroidectomy. So we had 98.5% of patients moving to total thyroidectomy in 2020. Now we have a bit better. We have reanalyzed this data again this year, and we have like 93% of patients going to total thyroidectomy, like 6% only going to lobectomy. So it is a hard task to make. I think I'm talking specifically in Argentina, to move the whole population to lobectomy. It has been really very, very slow, and we have performed an investigation from our thyroid department in our Argentinian Society of Endocrinology, just to show the whole community of endocrinologists that lobectomy is perfect, we can do that. So I think it will take some time for this to be accepted by endocrinologists, by surgeons, and even for patients.
I see. It's a bit different from the Japan and Argentina.
Yeah.
We started from lobectomy to total thyroidectomy for based on the risk stratification. So, okay, may I proceed?
Yes, sure.
Yep. So, question number 2. It's well known that age is an important predictor of progression in active surveillance of low-risk PTC, non-operative cases. It's believed that while low-risk PTC tends to progress somewhat in younger individuals, it often ceases to grow later. In this study, however, age did not emerge as a significant predictor. No growth cases a bit younger. How do you interpret this finding?
Well, mainly we know that we are talking about a small number of patients for most of these studies that do not find any impact on age. And also when we see this for low-risk papillary thyroid cancer, maybe we are considering, of course, larger studies. Your study also showing no increase in older or less increase in older than 50 years old. Here we are in the middle-age population of patients, and the follow-up is not 10 years for most of these patients. So it's very difficult to affirm that metastatic low-risk papillary thyroid cancer will not be acting as it happens when it is in the primary site, because we see that probably this is pretty the same that happens with the low-risk primary papillary thyroid cancer. I have not an answer to determine this, but this is what we saw, no impact or age, and this was not seen either by any of the previous groups who analyzed this variable in patients with lymph node metastasis. But we have to consider that this is not, to my knowledge, this is not an experience as active surveillance when we have thousands of patients done this, and we have only small groups of retrospective studies, and probably this need to be better characterized.
I see. Actually, it's no problem, or it's depend on the patient number. But our experience, as I shown the one case, young patients often show the lymph node metastasis, very small one, and we urge to the active surveillance, and most of them do not show any progression even in the younger patients. So I wonder if that there's some different mechanism in thyroid gland and the lymph node, maybe as some cancer microenvironment or something. I don't know.
Yeah, probably. But when you're talking about the lymph node that is surrounded, the metastatic disease is surrounded. It's not in the middle of a parenchyma or in the lung, where you do not have something who can not permit the growth. So probably maybe that the lymph node acts as a container of the metastasis, not allowing this progression. Maybe, I don't know.
Yeah, it's a very interesting case. So, okay, 2 more questions. Sorry. Listen, recently, some ablation techniques like radio frequency ablation for papillary microcarcinoma and lymph node metastasis have become a topic of discussion. Actually, unfortunately, we have few experience in those kind of interventional methods in Japan, except for ethanol injection. Could you share your thoughts on the selection criteria for active surveillance versus summer ablation, if you have any?
No, we do not have here. It is not reimbursed here in Argentina, so it depends on the payment of the patients for going these procedures. And maybe if we have a maximalist patient who do not want to do a surgery, but he wants to do something with this metastatic lymph node, we probably indicate these as an alternative. But we have seldom cases with these procedures done. And I cannot talk about Argentinian experience on this because it's really very, very low. It's really low. We do not have experience.
Yeah,
and I don't know what's happening in the US with Mark and the use of RFA right now.
Yeah, it is definitely, there are more and more clinicians who have obtained training. I think it's more utilized in patients who do not want to undergo a surgery for a primary tumor in the thyroid. I don't know what the collective experience is for lymph node metastases. I think their alcohol ablation is the more common modality for non-surgical management.
Okay. Thank you. So my last question. Yeah. Last question. Local regional recurrence of thyroid cancer has a significant psychosocial impact on patients. Is there anything specific you pay attention to in shared decision making with patients? Do you use the term cancer recurrence in those theories?
Well, this is an impression. This is not a study we have done. But my impression is that when we have a primary papillary thyroid cancer localized in the thyroid, it's much more difficult to say the patient we could undergo active surveillance. These patients in Argentina, they will surely move in 70% of cases to surgery, and it continues being the same in 2014, where we had 2017 when we had our first publication. It was 70% the acceptance of active surveillance of surgery, only 30% of acceptance of active surveillance, and it continued being the same in 2024, almost 10 years later, that we performed the same study this year, and the acceptance continued being 30%. Very different to what it happened in Japan, because it was very low, but then 10 years later, almost 90% of patients were accepting active surveillance. But my impression is that with lymph node metastasis, the patient already underwent the primary surgery, already knows what happens with the surgery, already knows what it's going to come, all the stress to the surgery from the surgery. So they are not reluctant, they are more prone to accept active surveillance of the lymph nodes. We have plenty of patients with tiny, small lymph nodes of 8 millimeter, very suspicious. And we explain that this has, we always tell our patient what they have. They have a lymph node that is suspicious of metastatic cancer. So we speak to them really what they have. And I don't think that hiding the word cancer will make the patient understand or be less afraid. At least in Occident, we want to explain everything, and we want that our patient is very conscious with the decision we are taking together, because this is a together decision. So I think that this word may not have the impact it has with the primary diagnosis of papillary thyroid cancer. We have to offer the active surveillance for the first time. So patients are more prone to accept that active surveillance of lymph nodes.
I see. Do you always perform the fine needle aspiration for every suspicious lymph nodes? Because, no.
No, at all. We
Okay.
follow we follow the recommendations with this tiny, small, suspicious lymph node of observation. But of course, for this study, we wanted to do it with fine needle aspiration proven metastatic disease. So there were like 30 patients that were not included in the analysis.
I see. Same here. Thank you. So thank you very much.
Yeah, thank you both for your presentations. These were extremely insightful questions. I wanted to address one question from our listeners, and the question is for Dr. Pitoia as to whether any of the patients before active surveillance had radioiodine ablation after their thyroidectomy.
Yeah, here, this is also bizarre because almost 82 or more percent of our patients had, 92% of our patients had a remnant ablation. So these were patients who received remnant ablation, even having a low risk of recurrence. Mainly the group of patients who we do not ablate routinely right now. There are a group of patients here from 10 years before, and this is something that we need to discuss better. Mainly we are a referral center, and we receive patients that were already treated at other centers, and sometimes they already come with remnant ablation. At our center right now, we do not perform a routine remnant ablation for low risk and even for intermediate risk of recurrence. So most of these patients who were under active surveillance already received a remnant ablation with radioiodine.
So I'd like to circle back to that last question, and it really relates to patients' acceptance. I think all of this comes back to counseling for patients and how you present the information. But I have to assume that a patient who undergoes primary surgery and then develops a recurrence, their mindset and how they think about that recurrence is very different than a small primary cancer within the thyroid. Intuitively, it would seem that patient population has to have a higher level of anxiety to think that their cancer has come back after initial surgery and radioiodine, if indeed that was administered. Can you speak to that, both of you? Because there seems to be a disconnect here in terms of patients who and how they're thinking about their disease process.
It's interesting, this difference you perceive among patients from the US and what I perceive from our patients here. It's interesting. Probably when I explain this patient, this recurrence, I explained that this is a persistence, that this is it comes from the very beginning. The tumor was diagnosed, but it was very tiny, very small at that moment, and probably not diagnosed. That then 1 or 2 years later, it appears a small lymph node in the neck. And probably this is an impression. I don't have data to show this, but my impression is the patient feel more comfortable with recurrence, understanding that this is not something that is exploding right now, but comes from the very beginning, and we are discovering this right now because it is now visible or evaluable. So this is my impression. I don't know, Dr. Sugitani, but probably Japan is completely even different.
Yeah. We usually recommend at least for low risk or intermediate risk pancreatic cancer patients. At first, we explain the concept of the subclinical or non-harmful cancer. Such concept exists, and the term of recurrence is very impactful for those patients. So we explain that when we perform the conservative treatment like lobectomy without radioactive iodine. So the rate of recurrence is a bit higher than the aggressive treatment like total thyroidectomy with radioactive iodine. But we explain that it's not a recurrence, just persistence or remnant. So only for that explanation can reduce the patient's anxiety, at least for Japanese patients, I think.
Okay, so let me tell you what, if I was just landed on the planet Earth and entered into this discussion of cancer management and looked at our criteria for active surveillance versus surgery for low-risk thyroid cancer, the presence of a lymph node would push us towards doing primary surgery for patients when they're first diagnosed. Or certainly the detection of a lymph node after beginning active surveillance would push us to treat. So we've got this a bit of a mismatch here in terms of the mindset. So maybe if you could please address that.
I like to hear the one who has the most experience for active surveillance here, who is Dr. Sugitani. So what his opinion on this?
Yeah, one idea is that active surveillance can remain the very small lymph node, or always we remain the very small lymph nodes when we perform active surveillance. So if we perform the surgery at first, those kind of lymph nodes can progress afterwards, even if the patient had aggressive surgery. But we don't usually perform the prophylactic lymph node dissection. So those kind of lymph nodes remain at the site, even the patient had surgery. So if we perform the active surveillance, when lymph node developed clinically evident, we can treat them one surgery. But if you perform the surgery at first, those kind of patients have to have second surgery. So that's one of the explanations for those situations.
Okay.
It's completely interesting what Mark says, because it's real. We are moving the pendulums a bit more, and then we do not know where to stop that, because if we think about this and we say, well, active surveillance for a lymph node, active surveillance for the primary, where we can do active surveillance for the two situations happening together in a patient. If he or she has a small, tiny lymph node, and probably this can be done also with no risk, but there's no answer until this moment for that.
So how do you think your patient population, and we talked about this, would act if they were given the alternative of perhaps alcohol ablation versus active surveillance? If you offered that, how do you think that would sway their decision-making for the emergence of a clinically evident lymph node?
Probably I'm biased, because I wouldn't suggest ethanol ablation for these patients, and probably this situation prevents me to understand how would be the reaction of these patients. I think they would be very comfortable with the active surveillance instead of moving with ethanol ablation. But it's my impression. I don't know.
Dr. Sugitani, do you want to just comment on that?
unfortunately, we don't have much experience in interventional thermal ablation therapies. But if we don't need to do anything, don't do anything.
Okay, words of wisdom to end on. And speaking of words of wisdom, this is the podcast that I mentioned that Thyro has launched. I welcome all of our listeners to listen to the very first one, which happens to be Dr. Tuttle talking about radioiodine resistant thyroid cancer. And so with that, I want to extend my tremendous amount of gratitude to Dr. Pitoia and Dr. Sugitani for their presentations, to all of our listeners for joining us this morning, and certainly welcome you back next week for another Thyro presentation. So everybody stay healthy, and thank you very much for joining us.